Good morning, everyone. Governor Scott is currently on another call with fellow governors and White House officials, but he will be joining us shortly. I'm Mike Smith, Secretary of the Agency of Human Services. Today, I'll start by giving an update on Vermont's vaccine rollout. Commissioner Pichek will present our weekly modeling, and Dr. Levine will provide a health update. I'll start off by letting you know that Walgreens will be one of the pharmacies in the federal pharmacy program and will be getting vaccine distribution directly from the federal government that is above and beyond our state allocation. We've reached out to our federal partners to see what Walgreens will be receiving each week in terms of dosage and when their clinics will be available to Vermonters. This is what I know so far. It is anticipated that it will be between 1,000 and 2,000 doses a week. This program is slated to begin at the end of this week. When we have more information, we'll connect to our website. We'll put that on our website, and if you are 75 years or older, you can register for the federal vaccine program by going to either the Vermont Department of Health website or by clicking on the link at the Vermont Department of Health website that will have the Walgreens website, or directly on the Walgreens website. This is the only information we have on the federal program right now. Our understanding is that they are only scheduling a week at a time. We will issue a press release as soon as we have information on this more information on this federal program. For your reference, we are being informed that there are about 20 Walgreens locations across the state that will offer vaccines, and 4 of them are located in the southern part of Vermont, where we wish to add more sites, and so that's good news. Again, if you are 75 years old or older, you can register online, and we will share the link as soon as we have it. As of today, 65,100 eligible Vermonters have been vaccinated against COVID-19. 36,600 Vermonters received their first dose, and 28,500 have received their second dose. 33,400 Vermonters aged 75 and older have registered for their first dose through our community vaccination program. And so far, 32% of Vermonters in the 75 years old and above age group have been vaccinated. As of this afternoon, 240 first doses will be provided to homebound Vermonters receiving home health services. The initial vaccine allotment designated for home Vermonters last Friday included agencies covering Caledonia, Franklin, Windsor, and Windham counties. This week's allotment includes agencies covering Addison and Washington counties. Additional allotments have been designated for AM Care EMS to serve Northern Franklin County and Rescue Inc. to begin vaccination in Bennington County. We anticipate Chittenden, Grand Isle, Orleans, Essex, Orange, and Rutland counties to begin next week. As I mentioned last Friday, we recognize that there are homebound community members that need to be vaccinated that do not currently receive home health services. Once the initial grouping of roughly 2,000 statewide individuals that do get home health services are engaged and receive their vaccine, will turn to this other group of individuals that don't receive service through the home health agencies. I anticipate that we'll be through this first group, the 2,000 that I mentioned, the roughly 2,000, in the next few weeks. Dr. Levine will address the BIPOC clinics that were held this week, and he'll have more to say on that in just a minute. This week, Grace Cottage Hospital, serving Windham County, and Northwestern Medical Center in Franklin County will begin vaccinating community members aged 75 and older. A clinic in Beecher Falls, serving Essex County, will begin vaccinating community members on Friday, February 12th. Mount Ascutney Hospital and Health Center in Windsor County, Copley Hospital in Lamoille County, Gifford Medical Center in Orange County, and North Country Hospital in Orleans County are anticipated to start vaccinating Vermonters 75 and older next week. Individuals in Group 1A will continue to be eligible to receive vaccine. Hospitals receive ongoing allocations of vaccine for the purpose of vaccinating this group. We are not adding additional designations to the 1A group. Only those professionals already identified as healthcare workers are included. We know that eligible individuals in Group 1A will continue to fluctuate as people change their minds, as newly Vermonters are hired or contact the hospital to identify themselves as healthcare providers. I want to just quickly mention that there have been reports about people getting vaccine when they did not qualify. This is unfortunate because we sent out 3 health alert notifications to healthcare providers talking about who was eligible in Group 1A that were specific, especially regarding healthcare workers. In addition, we heard about situations where there's an attempt to circumvent the guidance, and we intervened. However, despite these unfortunate instances, I still have a high confidence level that most healthcare providers and workers complied with the guidance and those eligible got their vaccines. We are hoping that this will be less of a concern as we move forward. We have issued even more guidance for healthcare providers. Eligible individuals in Group 1A should contact the hospital in their area to register. Please do not try to register at the Health Department's registration site at healthvermont.gov/myvaccine website, as this is currently only available to Vermonters 75 and older. Vermont is making substantial progress in Phase 2 of COVID-19 vaccinations, focusing on those 75 years and older, which helps us with our primary goal, saving lives. We will keep Vermonters informed when eligibility will expand to the next group, but even if your age group is not yet eligible, you can still get a step ahead by creating an account in our system. That way, when your age group is eligible, it'll be easier to sign up for your first dose. Learn more at healthvermont.gov/myvaccine. If you are 75 years and older, we ask you to please register soon by going online at the Health Department website at healthdepartment.gov/myvaccine or call our registration call center at 855-722-7878. We will be moving to another age group soon, and although 75 plus will be eligible to be vaccinated no matter what age group we are in, other age groups will be added for available appointments soon. Lastly, the state of Vermont will be offering a COVID special enrollment period from February 16th, 2021 to May 14th, 2021 for those who do not currently have health insurance to enroll in a qualified health plan and receive premium and cost-sharing assistance if eligible. Sign up for the specific special enrollment period must occur through the state's customer support center at 855-899-9600 and cannot happen online. The Consumer Support Center is open Monday through Friday from 8 a.m. to 4:30 p.m. and will be closed on state and federal holidays. The Department of Vermont Health Access previously opened a COVID-19 special enrollment period in 2020 in response to the public health emergency to provide a path to coverage for uninsured Vermonters who are not eligible for Medicaid. In reopening the COVID-19 special enrollment period in 2021, Vermont will join with marketplaces nationwide in providing an additional opportunity for qualified health plan enrollment. More details may be found at diva.vermont.gov/COVID-19. The special enrollment period will be available from, like I said, February 16th, 2021 to May 14th, 2021. And now for a update on what's going on in Vermont in terms of modeling, I want to turn it over to Commissioner Piczek.
Thank you very much, Secretary Smith, and good morning, everyone. This week, we did see continuing improvement across the country and across the Northeast. In Vermont, while our cases have not improved as significantly over the past 2 weeks, we are continuing to see fewer cases among our most vulnerable populations, which is continuing to keep our fatality rates low compared to the rest of the country. Finally, today, we also plan to preview some early data out of Israel, where over 80% of their population aged 60 and older have been fully vaccinated. And they're starting to see early signs of hope, with severe illness and deaths starting to decline. New cases in the United States continue to drop this week, marking more than 4 weeks of improvement, during which time cases have fallen by 55%. Additionally, the number of people hospitalized across the country continues to see significant improvement as well, down over 30% from its most recent peak. Unfortunately, new daily deaths remain high. However, if we keep in mind that those who are passing away today from COVID-19 were likely infected during the early to middle part of January, and since that time, we have seen a significant reduction in new cases, both across the country and in the region. Accordingly, we anticipate to see significant reductions in new deaths in the weeks ahead. Additionally, the CDC's most recent combined forecast, which integrates dozens of leading models from across the country, anticipates that cases, hospitalizations, and deaths will continue to decrease through the rest of the month of February. And further good news, over the past few days, the United States has already outperformed this model. Closer to home in the Northeast, we saw a significant improvement in the region as well, with close to 30,000 fewer cases this week compared to last. When combined with the decreases we have seen over the past 3 weeks, cases in the region have decreased over 50%, with hospitalizations and deaths trending down as well. Taking a look at the regional heat map from January 11th, when cases were at their peak, compared to today, you can quite clearly see this improvement, with significantly fewer cases in urban areas like Boston and Hartford and Albany, but also significant improvements in the more rural parts of our region in upstate New York and across New England. The improving situation around us certainly bodes well for Vermont in the weeks and months ahead. Finally, our regional forecasts indicate that cases will continue to trend down throughout the month of February and into March. At that point, we will also have made significant strides in vaccinations, and warmer weather will be just around the corner. So all of this points to very favorable and optimistic news. Here in Vermont, this week we crossed the 13,000 case threshold, reporting 959 cases, an increase of 90 cases compared to last week. Looking closely at Vermont's 7-day case trends, we can see that the case average is down 30% since the most recent high on January 13th. However, we also see that over the last 2 weeks, our cases have remained generally flat. Looking at the geographic distribution of our cases, however, we now see that both Bennington and Rutland counties now stand out in terms of their disproportionate number of cases, which is having an impact on our statewide average. Over the past 4 weeks, cases outside of Bennington and Rutland counties have decreased close to 40%, while cases in those two counties have increased by over 70%. The good news, however, is that over the last few days, there have been some recent improvements in those counties. However, the cases are still disproportionately high, and Vermonters who live or visit or work in those counties should be particularly careful at this time. Looking at our cases by age, we see that we recorded a similar number of cases that were over 65 this week compared to last. However, those more high-risk cases continue to be a smaller percent of our overall case numbers and are reducing in their aggregate number as well. Further, among our most vulnerable high-risk cases, those residents living in long-term care facilities, we have continued to see considerable improvement throughout the month of February among this most vulnerable population, which has continued to keep our fatality rates very low into February, with Vermont currently maintaining the lowest fatality rate per capita in the country. And again, as we vaccinate more and more of our most vulnerable over the weeks and months ahead, as Secretary Smith pointed out, we anticipate seeing fewer and fewer of these high-risk cases, which will in turn mean less severe illness and less deaths. The reduction in long-term care cases is reflected in the lower number of active outbreaks that we're seeing in these facilities as well, down to just 5 active outbreaks this week. Again, continuing good news among that most vulnerable population. Regarding hospitalizations, we see that usage remains high across the state. However, our statewide hospital forecasts continue to have us safely below our available statewide resources over the next 6 weeks. Further, just like we saw with cases in Bennington and Rutland, hospitalizations are also disproportionately high in those counties, with about all of our hospitalizations currently located in those 2 counties. The same is true for the ICU usage as well. Again, where about half of our currently hospitalized individuals in ICU units are in Bennington and Rutland counties. So while our hospitalization numbers are high and trending up in recent weeks, much of the region, much of Vermont has seen improvement while cases have remained high in Rutland and Bennington counties along with hospitalizations. Again, hopefully starting to see some improvement in those counties, but just like all Vermonters should be cautious and vigilant, particularly those who live in Bennington and Rutland County should be at this time as well. Turning to college restart, this week, colleges across Vermont reported 91 new cases on campus. Again, with elevated level of cases in the region and in Vermont, it's not surprising that there's a higher number of case counts so far this semester. In fact, throughout the spring semester, we've already surpassed the number of college cases we saw all of last fall in just the first 3 weeks of restart. But again, this was anticipated, and they should improve as the semester continues. Now turning to our Vermont forecast for the next 6 weeks, we continue to see that cases are expected to remain elevated through February and into March. And we certainly could see our actual numbers beat this forecast, and certainly we can have the power and ability to do so. However, we also do expect that even if we beat the forecast, that our cases will remain at a more elevated level for much of the month of February. Regarding the pace of vaccination in Vermont, the most recent CDC data from yesterday ranks Vermont second in the Northeast in terms of vaccine administration and number 10 nationally on this metric as well. Finally, I wanted to preview again some early data out of Israel. We've been watching Israel closely because they have been focusing on their most vulnerable population, those that are over the age of 60, and have had a really aggressive rollout of the vaccine. Again, close to 90% of individuals in those age groups have received their first vaccine shot, with close to 80% having been fully vaccinated at this time. And as you can see from the age case chart, cases are going down generally in Israel. However, they're going down more quickly currently among those age 60 and older. However, what is more significant when you look at the individuals who are experiencing severe illness, you will see that those that are 60 and older have seen a reduction of 13% over the past couple of weeks, while those in the younger age band have actually seen the number of those with severe illness trending up. So again, cases have been trending down for those over 60, and the number of severe illness in that age group is trending down more significantly. And finally, regarding fatalities, over the last few weeks, fatalities in that 60 and older age group in Israel are down close to 32%, while the fatality rate in that younger population has remained relatively constant over this period. If you see again how the progress we're making here in Vermont against those that are 65 and older to get them vaccinated as quickly as possible, that we have gotten over 30% of that population at least with a single dose, and are making good progress there with many of those individuals scheduled to get their vaccination over the next few weeks. We anticipate seeing similar results over the weeks and months ahead here in Vermont, with a reduction both in cases for those that are over 65, reduction in hospitalizations generally, but particularly in those over 65, and then again, maintaining a very low fatality rate over that period as well. And with that, I will now turn the presentation over to Dr. Levine.
Thank you. And just to begin with a little more data, we're reporting an actual low of 59 cases today. Somewhat different than the numbers we've been seeing between 100 and 150 of late. But unfortunately, 3 additional deaths, bringing that total to 186. You've seen some encouraging news regarding deaths from Israel, and we do definitely expect to replicate that experience here as we get our vaccination campaign under further movement. I'm pleased to report hospitalizations have come down somewhat to 53, ICU 13, and our 7-day positivity rate 1.7%. I've mentioned a few times now our plans to expand testing in Bennington County, which has been experiencing increased spread of virus. In the last week or so, there's been a slight downturn in cases, as you saw on the data slide, though they do remain well above the state average. And likewise for hospitalizations. Today, I can share 2 new opportunities in Manchester to help make testing even easier to access for people living in the northern part of the county, or for that matter, in the southern part of Rutland County. Remember, testing is the first part of containment of the virus. We've added 1 testing event this Thursday, February 11th, at the Dana Thompson Parker House on 340 Recreation Park Road in Manchester from 11 a.m. to 3 p.m. We've also arranged for additional testing on Saturdays throughout the month of February, starting this Saturday, February 13th. These events will take place at Northshire Medical Clinic, 5957 Main Street, Route 7A in Manchester, from 9 a.m. to 3 p.m. We're very grateful to the town of Manchester for their support and work in standing up these sites. We obviously do continue to have testing available on a daily basis in Bennington, at SVMC, and at our CIC site as well. You can make an appointment to be tested by visiting our website at healthvermont.gov/testing. We do hope Bennington County residents will take advantage of these opportunities as the first step in containing the spread of COVID-19. I also want to build on Commissioner Pichak's slide of Vermont counties by pointing out there are 2 other counties that show cases on the increase above the state average. I would like the residents of these 2 counties, Rutland and Franklin, to help keep their communities and families safe by going on offense against the virus, not only by keeping their guard up in all the usual ways, but also by considering seeking available testing in those areas. For those in Rutland County, there is daily access at Rutland Regional Medical Center, and there are slots open through this week. For Franklin County residents, please consult our website for opportunities across the county in Swanton, Enosburg, Fairfax, as well as daily testing in St. Albans at Northwest Medical Center. In fact, no matter what county you live in, we hope Vermonters will use testing as a tool in this careful balancing act, living our lives while staying safe during the pandemic. Testing is how we find the virus, so that people who are positive can isolate themselves quickly and their close contacts can quarantine. This is what can keep the virus from moving on to the next person. And I want all Vermonters to keep this in mind, because the steady pattern of cases we're seeing in the state is at odds with the declining cases across the region. There was a time when our capacity was limited, but we've come a long way in the world of testing. Now we have this essential resource across the state. We just need Vermonters to use it. Many sites allow you to take your own sample using a short swab in your nose, so it's quick and easy. Anyone can get tested, but we recommend it for anyone who gathered with people they don't live with, such as a Super Bowl gathering last weekend. You should get tested up to 2 days after the gathering and again on day 7. And if you have any possible symptoms of COVID-19, getting tested is even more critical. In our latest weekly data summary spotlight, you can see the timeline. Someone is exposed, they start to feel sick, they get tested, we get their positive test result, and contact tracing occurs. For most people, it takes 4 days for the health department to receive their test result. That's not because the testing is prolonged. We get the result within 24 to 48 hours. It's because the decision to decide to get tested doesn't get made right away. The shorter the time between someone feeling sick and getting tested, the sooner you can protect yourself and your community. And that no matter how mild the symptoms, you also need to stay home and away from other people until you receive a negative result. Remember, not everyone with COVID-19 has a fever, and even mild symptoms like a headache or dry cough could be signs of COVID-19. So test early is the punchline. I've talked a lot here about potential impacts of the new variant virus and our efforts to complete genetic sequencing on certain samples. I can report today that so far, the samples we've sequenced have not uncovered any variants of the virus. We are continuing this work to help Vermonters understand any changes in the virus that require even stronger adherence to our prevention efforts. Finally, you may have heard about some new efforts to vaccinate Vermonters in some communities where people speak languages other than English. At 2 clinics last week, we were able to vaccinate around 100 Vermonters. These clinics focus on households with members age 75 and older and their family members age 16 and older who require linguistically and culturally appropriate services. This includes working with cultural brokers, having interpreters on hand or easily accessible, and providing accurately translated materials. To reach these populations, we've been working very closely with partners such as AALV, Association of Africans Living in Vermont, USCRI, U.S. Committee on Refugees and Immigrants, LEND UVMMC, Leadership Education in Neurodevelopmental Disabilities, Age Well, and others. And I want to thank them for their collaboration and support. We have 2 more clinics planned for later this week. We understand that language barriers and other factors faced by immigrant and new American communities have led to outbreaks, disproportionate outcomes, and a markedly greater risk of COVID-19. I'm proud that we've been able to take these steps quickly to align with our data-driven approach to prioritize those most at risk of severe illness and save lives. Throughout our vaccine planning stages and in the past weeks of vaccine deployment, Secretary Smith and I have been very clear and candid describing our efforts to appropriately prioritize our BIPOC and English language learning population in Vermont. These efforts align with recommendations of the CDC and our own Implementation Advisory Committee. We have spoken of the linguistic, educational, and communication needs of this population, as well as the importance of providing access to vaccination itself, and what we would do when an elder in the 75-plus age group was identified and was living in a multi-generational household, which itself is a very strong risk factor for COVID transmission. We have learned from our experience through the state's pandemic response that it makes good public health sense, logically and logistically, to allow household members facing language and access barriers to get information and services at the same time, rather than duplicate these services later on. We still have much more to do to address the significant disparities in the rates of COVID-19 infection, hospitalization, and death among communities of color. But we hope this coordinated vaccination effort is an important step in working with trusted community partner networks to reach some of the most historically underserved people in Vermont. We have understood the need to maintain transparency and trust throughout this complex vaccine planning process and have clearly communicated these plans and the public health data and scientific reasoning behind them during these very press conferences. And we will continue to do so as we work to reduce community transmission and prevent outbreaks across our state. We will start our question and answer period now, and when the governor arrives, he'll make his comments.
All right, as we let the reporters know beforehand, we do have a hard stop at 1 o'clock today, so we're going to take 2 questions and then move on to the next person. If anybody has an additional question at the end, send me a note and I'll circle back if there is time before 1 o'clock. We'll start with Calvin.
Thank you. So, Dr. Levine, so you mentioned that, or Commissioner Pichek mentioned that we're seeing pretty big spikes in Bennington and Rutland. I'm wondering, if you can point if there's maybe a specific reason as to why, or I guess what sort of pattern we're seeing in some of these new cases.
Yes, so in both of them, there have been modest outbreaks, but they don't explain the vast numbers of cases that we've seen. They're nothing like what we saw months ago in Washington and Orange County that emanated from the ice rink episode. The outbreaks that we're seeing are very modest size in both of these counties. We've also noted previously that a certain smaller percentage of the positive tests are New York residents who may be coming to recreate in Vermont or may be coming to work in Vermont and who may receive their health care in Vermont. We've also noted another percentage that may be related to ski travelers coming to our resorts. And then finally, we have just abundant situations and outbreaks across a number of work sites, schools, and long-term care facilities like we do in other parts of the state. I would say the predominant cause of the increase in cases is at this time community transmission in those kinds of situations. Same for Rutland County as far as we can tell at this early juncture. And that's why it's really important for Vermonters to be cautious, follow the guidance, but also avail themselves of all the testing opportunities I noted.
And then you also mentioned that this steady pattern of cases that we're seeing in those counties is at odds with what we're seeing in other counties across New England. Specifically looking at the forecast, it looks like everybody else is going down, but Vermont is going up. I guess why is that?
Yeah, well, keep in mind we're starting at a very far lower number of baseline cases than most of the rest of the regions. And we've gone up slightly. We're kind of plateaued at this point in time, but that again is at odds with the decreases we're seeing elsewhere. It's challenging to find a particular reason for that because we really can't in any of our outbreak work or in any of our contact tracing work find a reason that we just sort of have plateaued in this region. I'm heartened by the count from yesterday that I just announced here, and we'll have to see how things go. I'm also heartened by the hospitalizations going down. So hopefully, much of what we're seeing in Bennington County particularly is on the true downswing. And since that accounted for, as you saw on the slide, such a high percentage of what's going on in Vermont, that will moderate things quite a bit. We also have noted that Bennington County has started to look more like all of the adjoining New York State counties than the rest of Vermont. So hopefully that will moderate as well.
Steve?
In relation to the sort of the pressure that's being applied by the national NEA and even here in Vermont, trying to get back to school full-time, and they're saying, at least there's some pushback that the data is being misinterpreted or used for a different purpose by, the state and you folks to say, hey, it's all good. Do we have any hard numbers as far as, instances of either spread or cases in the schools, and then transferring to, say, adults or members of the public?
Yeah, so I'll speak, and then I believe Secretary French is on the phone as well. Clearly, we have cases in schools. We've had that from the very beginning, and almost never during the time we've been following these cases have the cases had such a severe impact that they required closure of many schools or closure of classes. And quite often it's because of staffing considerations due to quarantining staff that schools have had to do one of those two steps. The actual impact, I think, was well seen in our discussion of school sports last week, where, yes, there's a very occasional case here or there where a member of a team came to practice and indeed may have transmitted the virus to one other teammate during that practice. But the most abundant was just a member of a team testing positive, usually from something in the community, and the team itself not being impacted. So that's kind of what we've been seeing all along in Vermont. I would say that transmission from student to adult has been on the rare side. It's most commonly either going to be adult to student or just self-contained within one person at a time. That's not been our experience. And certainly, as Secretary French has said on numerous Fridays recently, the positivity rate of the staff that have elected to get themselves tested has been a fraction of the state's positivity rate, usually on an order of magnitude of about a tenth. Secretary French, do you have any other things to add to that?
Yeah, thanks, Dr. Levine. No, I would just, echo the point that, when I listen to Dr. Kelso and our other epidemiology folks, there's pretty consistent theme of saying that, when we see cases in the community, we see cases in the school, and that's sort of the direct relationship. I don't think schools are viewed as a place where the virus is spread or originates. Usually it's a case where the virus is brought to school. And certainly, as Dr. Levine said, the surveillance testing is what it is, and I in defense of that, I think, we presented that in an open and objective way, and always been, from my view, careful to say this is just one point of information. I think it is important to acknowledge, as opposed to where we were last spring, that, on a daily basis, we have cases in our schools, and we sort of more or less, I think, to a certain extent, taken that for granted, though I can assure you, The school districts do not, and it's a tremendous amount of work on the part of school districts and the health department to manage those daily cases. Yes, they've become very fluent in doing that, and our data shows that schools continue to operate in spite of those challenges. But that's the context, and I would still conclude that, Vermont has some of the best conditions in the world, certainly in the United States, for educating our students. And I think that, yes, there are many headlines today about places in our country that are struggling with reopening their schools, and we've been open all along. I don't think we should be satisfied with where we are. I'm certainly very pleased with our response, but we should endeavor to do more because we have been so successful, and all Vermonters have been very successful in managing the virus from a community perspective, but also certainly inside our schools. So I guess my perspective is that we should, particularly as the warmer weather is on the horizon and the advent of more vaccine, we should aspire to do more and what's best for our kids.
Is there any place that the average Joe can go to take a look at the general number, not necessarily specific to a town or to a school, but the general number statewide of instances in the schools, that data that helps you to support that decision to let's get back to school?
We update that twice a week on our website. So at any point in time, you can see the historic context and also the current context of school cases.
Every school is listed and whether or not they've had a case. And there was also the weekly epidemiology data report recently that went through school outbreaks specifically. And I think found that 83% of school cases were not related to in-person, were not related to in-school transmission. So that's also on the Vermont Health Department website.
Thank you.
Governor Scott has arrived, so I'll let him make his comments now.
Thank you, Dr. Levine. Sorry I missed your presentation. Maybe I'd just like to start with some of the answer to that one as well, the previous question. I think everyone has to keep in mind, it's not just Vermont data. This is national data that supports this as well. The White House has come out with the same exact conclusion. So it's not just Vermont, it's across the nation. And I talk with governors on both sides of the aisle on a weekly basis, and they're finding the same reasoning. So again, my apologies for being delayed. I just got off the phone, another call with fellow governors, with the NGA and White House officials regarding COVID strategy. It was remarkable in some respects. Every single governor was on the call for this briefing, and we heard some good news, positive news for our nation as well as our state. The first is they will be distributing an extra 500,000 doses over the next 3 weeks. So what that means to Vermont, that's another 500,000 they're adding to this. So there will be up to 11 million doses distributing throughout the country. That will mean about 500 more doses, if I have my math right, 500 more doses for Vermont. The only complicated factor that factors into that is they also, and I wasn't able to, with 50 governors on, wasn't able to ask this question, but they made mention that they're going to start counting the 6th dose of the Pfizer vaccine that they haven't been accounting for previously. So this may skew it just a bit, maybe 50 doses or so, but we'll figure that out. But again, positive news in that respect. Having the 3-week supply, I think, is key for our planning. So I very much appreciate the way they're doing this. The federal government is also going to be launching a new program for community health centers, and they're going to be contracting directly with the FQHCs. So we'll see how that works. It appears that there will be 250,000 doses total being distributed directly to the FQHCs beginning next week, building up to 1 million. But again, the other complicating factor in that is that they're counting both first and second dose within that 1 million. So right now we don't account for that, but again, positive news. It could be 250 doses for FQHCs in Vermont, but we're going to have to, the details do matter, how they're going to register and how we're going to be able to interrelate with that is going to be important. We also discussed some new second dose protocols for the very few people who don't come back for their second dose. There's going to be a provision for 42 days if they don't come back to get their second dose within 42 days. It could be used as a first dose. So this is something new that we'll get some more details as well. And lastly, we heard some good news about production from Pfizer. They have announced to the federal government that they are going to add 50 million doses more than originally thought before the end of March. So they're going to go from 100 million to 150 million, which is significant. So we touched upon some of the Johnson & Johnson, but no new news in that area right now. But maybe next week we'll have some more discussion on that. So I appreciate the continued weekly communication between the governors and the White House, and more details will be forthcoming from Washington. Next, it's important to know, even as we vaccinate more Vermonters, testing continues to be a critical tool. I realize some may have gathered for the Super Bowl or other events this past weekend, and we want to do all we can to slow the spread of the virus as a result. So if you got together with people from outside your household or recently traveled, or just want to make sure you're not infected, please get a test. It's free and easy, and we have plenty of capacity. As noted in Commissioner Piechek's modeling, we've seen increased activity in Bennington, Rutland, and Franklin counties, so I urge folks, in particular from these counties, to sign up for testing as well. And you can register at healthvermont.gov. Finally, before we get back to questions, I want to provide a quick update on the 1099 exposure at the Department of Labor. As my team is working to finalize a contract to provide identity theft protection services, I want you to know that we take this breach seriously. And although we believe this incident involved only some of the 1099s that were mailed from labor, we'll be providing these services to all 2020 unemployment insurance claimants. They'll be able to enroll in identity protection services by next week, if not sooner, and at no cost to the individual. Information and instructions will be mailed to those affected. And again, we urge all claimants to sign up. It's important to note, as soon as the person enrolls, the protection will be retroactive to the date of the breach. My hope is that this will provide some reassurance, though I know it doesn't come close to making up for the harm and worry that this has caused Vermonters. Many have asked about the costs associated with this breach. Fortunately, before this happened, we purchased cyber insurance to protect Vermonters affected by incidents like this. So instead of this costing many millions, it will be significantly less. We'll need to, of course, cover the $250,000 deductible, but the insurance will cover the rest, which is some good news. Again, more details on the services provided and instructions on how to sign up will be sent directly to claimants, but I wanted to provide an update to let everyone know we're moving quickly to protect identities and to fix this problem. And with that, we'll open it back up to questions.
All right, we'll go to Stuart, NBC 5.
Thanks. Question about the 70 plus, 75 plus age banding. I think Secretary Smith said that you would move 70 plus soon. The number who have registered in the 75 plus seems to be relatively static, and I'm wondering if you sort of hit a cap there, and at some point we'll just have to move on, and when you think that might be. When you'll move on.
Yeah, I think we've talked about this a bit, Stuart, and we feel we're going to start registration by the end of the month, but we'll have some more news on that in the coming week. But at this point, you're right. I mean, we're getting to the end of age band 75, so we'll seamlessly move to the 70 and over from there.
Okay. And secondly, there was a prominent Vermonter who yesterday got some buzz on social media when he asked, at what point would Vermont consider grocery store workers, and aren't they at higher risk given the volume of strangers with whom they interact each day? Aren't they at higher risk, and would you consider vaccinating them sooner rather than later?
We're going to go through, again, our strategy that we took was to protect lives. We want to make sure that we're protecting those 65 and over, and we'll go through our age banding to do that, to accomplish that. As well, we feel that those with compromised health conditions, certain conditions, which would make them more vulnerable to death as well, would be included after we get through the 65 and over category. From there, we're going to contemplate what we do next, whether we continue with the age banding or we start doing certain categories. But it gets complicated. Every area, every sector, you'd be amazed at how many people lobby us for wanting to be next, because in some respects, we're all essential. So it gets more complicated as we move forward. But we're comfortable with what we're doing thus far. It's simplistic in some respects, and it accomplishes just exactly what we want to do. We want to reduce hospitalizations as well as reduce the number of deaths. And I feel that's a worthy goal.
Thanks.
Wilson, BAP?
Hi, good morning, everybody. Two questions. One on Commissioner Pichek's slide number 7, the regional active case forecast. It shows that, within a month from now, Vermont is projected to have the highest active cases per million in the region. And I know we're facing these increasing cases, but I'm wondering if someone can just comment on that one a little bit.
Is Commissioner Pichek on?
Yeah, Governor, I'm here. And Wilson, thank you, for the question. I mean, I think I would just keep two things in mind. The first being, Vermont, outside of Bennington and Rutland, has seen cases on the decline close to 40%, which is generally in line with the decreases we've seen around the rest of the region. But certainly the increases in those two counties have kept our statewide average a little bit higher. And the second thing is what that does is it impacts our forecast. So if our rates are higher relative to the rest of our own experience and the rest of those in the region, it's going to anticipate cases remaining higher through much of February and March. So that's the forecast. And as we've seen in the past, we certainly can do better than that. But the thing I took away from that forecast chart is really the fact that pretty much all of the region is trending down, and we'll see continued improvement, expected to see continued improvement through the month of February and into March. And certainly when the areas around us are improving and are at low case counts, it's going to be all the easier for us to keep our cases low as well.
Okay, thank you. And my second question, Secretary Smith, in your initial remarks, you noticed how you are aware of a number of situations where I think your wording was people have attempted to circumvent the guidance and we intervened. I was wondering if you could tell us a little bit more about that. Is there any potential criminal liability for people who try and jump the line, or how are you policing this? Or maybe policing is the wrong word to use. How are you dealing with that situation?
I wouldn't say there's any criminal activity associated with it. Where we saw it once is where there was some attempt to not do patient-facing healthcare workers, and instead using it to do non-patient-facing healthcare workers, and we intervened at that point. We saw an email. We intervened, we stopped it, and it never happened in that facility for that episode. So that's what I was talking about in our intervention in those. When we see it, we intervene because it's not right, and we want to make sure that we are looking at these in general. I do want to put it in perspective, though. I think, in general, the people that are supposed to be getting vaccines are getting vaccines in that healthcare worker group. And I just wanted to alert that we have seen instances where there has been an attempt to circumvent the guidance. I don't think it probably wasn't intentional. They were just misreading the guidance or hadn't read the guidance in terms of what the guidance said. But at the same time, I got to recognize that probably some people have gotten vaccines that shouldn't have, and that's unfortunate. And we are always looking out for that and trying to make sure that those healthcare partners that we have really enforce the guidance that we've put out there, and that individuals look really deep in their heart and say, is this something I'm qualified for or not, as they sign up for vaccines.
So you mean as someone who might work in a healthcare facility, but they don't have interactions with patients where they would be more likely to be exposed? Is that what you mean?
That's what I mean. Administrative people, for example.
Okay. Okay, perfect. Thank you very much.
If I could just comment a bit further on that as well. We didn't have as much control in 1A, and it was fairly new when we started the vaccinations in Vermont. We probably should have been a little bit more clear, but it was moving quickly. And I think now we've got that more under control and have been more clear in our guidance as to what our expectations are. As well, I think this is a benefit, again, of the age banding. It's fairly clear. You're either in that age group or you're not, and there's no ability to kind of be subjective about it. So that's the other beauty. And so now that we've gone to the age banding, I don't see that we won't find some of the opportunities that existed before.
Okay, thank you.
Cameron, St. Albans Messenger. Cameron, it's *6 to unmute. All right, we'll go to Mike Donahue, the Islander. Mike? All right, we'll try Howard at VPR.
Yeah. Hello?
Go ahead, Howard.
Can you hear me?
We can.
Okay. For Secretary Smith, I know that some federal money was used to purchase some motels for folks who are experiencing homelessness. I'm wondering, when the federal money runs out, what's the plan after that? I'm wondering, even when we're at herd immunity, do you expect to go back to the way things were before, or are there some lessons we've learned in this? What can you tell me about what your team is working on when we're beyond this?
Yes, thanks for the question, Howard. Obviously, we have almost, probably pretty close to maybe even over 2,500 people in a motel hotel program right now. When the pandemic hit, we tried to bring everybody that was homeless into an environment that was safe. Obviously, we're spending probably 10 times more than we normally do in that hotel-motel program. That's unsustainable, as you have mentioned. We have to, once vaccinations start taking hold, once it starts getting safer, we have to move for not only for fiscal reasons, but for the health reasons and security reasons of those individuals in those motel situations. I think, what we need to do is wrap services around them, which we're doing, but more permanently than this sort of temporary measure that we have. So the game plan is to go back to what we had originally thought about, which is our community-based programs, and redesigning our state program to enhance a community-based program with dollars and with flexibility to help with creative homeless solutions. We're going to have to start transitioning that as we come out of that pandemic. And in our budget, we have started to do that as we look forward to the fall and when we really need to transition out of this. People in these programs, especially families, need permanent housing and they need support services in addition to that permanent housing. Hotel motels aren't the solution here.
So do you think there's going to be a time when the federal money runs out and there's going to have to be some kind of a bridge between those two plans?
Well, I think you'll see them overlap is what we're looking at. I don't, the hotel motel program isn't going to end, but right now, as I mentioned earlier, it's unsustainable at the price tag that it's at, almost 10 times more than what we've normally paid for this. So I think there's going to be an overlap, and we'll time it so that the FEMA money has been extended. We'll time it so that we can use that overlap period to do a transition. We're going to do a gradual transition because you've got to do a cutoff, a complete cutoff would leave people in a dire situation, and we're not going to do that.
All right, thank you.
Pat, WCAS?
Hi. I'm going to push back a bit on your comments that you've been very clear and candid about the plans to vaccinate multi-generational households in these new American communities. Judging by the feedback I've gotten from our viewers over the past couple of days, it's caught a lot of people by surprise. The only specific reference that we found to incorporating people who were not 75 plus into these clinics at one of these briefings was a small comment made by Dr. Levine nearly a month ago. And then as recently as Friday, Secretary Smith said, quote, "We will continue to allocate more for that community in the age group 75 and up." To anyone listening, that sounds like you're vaccinating only the folks ages 75 and up at these clinics. It's also a little bit in stark contrast to your approach in talking about the age banding, which gets brought up and explained in great detail at each of these briefings so that people understand why the state is taking this approach and the data that supports it. Are you sure that your messaging on the specifics of your outreach to the BIPOC community was clear?
Dr. Levine.
Thank you, Kat. I'm glad you were able to find that clip as well. We've gotten asked long before we actually even had vaccine, we've gotten asked multiple times about our position regarding the BIPOC community and would there be some element of prioritization for that community. And I think we've been very consistent all along in saying yes, and as it got more well-defined, we got more specific about that. The age banding is still the number one strategy, and indeed, if you're a member of a multi-generational family in the BIPOC community, you don't get recognized for the opportunity to have the family vaccinated until you have an appropriate person in the age band. So we've seen some of those in the 75 and older and have taken the appropriate action, as I described in my opening comments. Same thing will happen as we go down 70, 65, et cetera. One thing that's characteristic of this community is that it does skew younger in the total age range. So it was actually pretty unusual to find some 75-year-olds actually in those family units. And we were very happy to accommodate as we did. But I do think, if people have been surprised by the position, it's probably only because it wasn't so relevant for such a long period of time. because we had nursing homes and long-term care facilities. We had Group 1A take up quite a bit of time before we got to the actual age banding position. So there could be, understandably, people who weren't in touch with what we were saying previously because it hadn't really come up a lot during that extensive period.
I think questions about what the outreach to the BIPOC community has been have come up at just about every press conference, and I'm questioning why recently this wasn't brought up as one of the specific outreach points to that community.
Oh, frequently we've talked about the need for us to make sure that education, communication, linguistically appropriate materials and conversations were occurring, that we were partnering with all of our organizations that I recited previously, and in addition, that we would address the issues that were very real regarding access to the vaccine, so that if people were agreeing to take the vaccine, they actually could access the vaccine as well. So I would just say that I think we've been very clear in those kinds of communications.
So what is your message then to Vermonters and also other multi-generational households who've been told that they and their families need to wait? Can you just explain for them quickly what the difference is so that they understand?
We're going to, again, it was a 2-question limit, so I'll let Dr. Levine answer that question, and then we can come back to you at the end if there's time.
Thank you. I imagine there may be some other Vermonters who may live in multi-generational households and may have some of the challenges of the community we've described. Most of the time, the challenges to this community are quite unique, and I've described them previously. The data has supported the fact that there have been outbreaks in members of this community. Their outcome measures have not fared as well as the rest of Vermonters, and we really wanted to remedy that. The number of risk factors that they possess, including the fact that there's multi-generational housing, have really been abundant, including the kinds of public-facing work they may have, the need to take public transportation to get to that work, and the fact that they have generally had less access to all of the information that everyone else has more access to. So, hope that answers your question.
Thank you.
All right, folks, just again, a reminder, 2-question limit. Sorry I missed it there for the rest in the queue. Next up is Greg at the County Courier.
Good afternoon, Governor. Thank you, Rebecca. I still have not received information from Friday's press conference about the health department's performing arts data or any outbreaks. But as for today, I'm hearing about at least several people that have traveled out of state, namely to Pennsylvania, to get vaccinated that don't qualify here in Vermont. But they do qualify there, and apparently there's no residency requirement. Are people like this counted in the state's data on how many people have become vaccinated in Vermont, or are they completely untracked?
I would guess, Greg, that they are untracked. I don't know how, if we didn't know that they were going there. I don't think there's a national database. I think it's just our database in the individual states.
Okay. And the other question, Governor, as you probably know, yesterday in Montgomery, there was a shooting incident where a man shot himself on a state highway in front of a grocery store. Obviously, members of the general public in the very near vicinity. This man was already facing felony charges for domestic assault with a deadly weapon, but state police opted not to release the man's name. I'm told that state police didn't even contact the state's attorney for consultation on potential criminal charges, which would obviously include reckless endangerment. Do you agree that state police should have shielded this guy's identity and keep the public from knowing who this obviously fairly violent individual is?
Yeah, I'm not familiar with all the details. I did know that there was a self-inflicted shooting in Montgomery, but I don't have any of the details on that. Commissioner Sherling, anything you can provide for an update?
No additional information, Governor. I'm going to have to loop back to the VSP team to get details to be able to respond in more depth.
I'd appreciate that. Thank you. Thank you, Governor. Thank you for your time.
Yep.
As always.
Lisa, the Valley Reporter.
Good afternoon. Thanks for taking my call. This question is for Secretary French. On Friday, you read excerpts from a survey of principals about how kids are doing emotionally, developmentally, and academically. That struck some of our readers as powerful and disturbing. Can more of the principal survey responses be made public with appropriate redactions made to protect student privacy?
Sure.
Okay, that was easy. And stay where you are, because my next question is probably for you too as well. Last week, the guidance was released on return to play for students. And we've received questions about students who are both on school teams and club teams. The guidance calls for students playing no more than 2 games a week. Does that include school-based sports and club teams? Can they play 4 games a week? Can they play 3?
I think that
Maybe I'll have Secretary Moore, if she'd be inclined to answer that. Secretary Moore has been sort of coordinating the school guidance with the rec sport guide.
Thank you.
Yes, thank you. I'm happy to. That's a very good question, and it is 2 games per week per team that an individual is rostered on. So they would be able to play 4 games per week if they were playing for a club soccer team and a school hockey team, for example, at the same time.
Great. Thank you very much.
Joe, the Barton Chronicle.
I know that for a while there's been some question about whether the vaccines that are currently available in the United States prevent transmission of the coronavirus. I'm curious as to whether now that there's been a large amount of vaccines administered, whether there's more information on that particular question.
So a couple of weeks ago, this is Dr. Levine, a couple of weeks ago, I believe it was AstraZeneca, did not publish in a peer review, but did announce some information they'd had regarding a decrease in transmission by about 2/3 in a subset of the people that they had in their study. They basically looked at nasal swab specimens over periods of time after the vaccine had been administered so that they could try to assess that. So that was really promising news, but very early, and was, to my knowledge, the first news since this whole vaccine effort has begun. So we're eagerly awaiting more news, and I suspect some of the other vaccine platforms that have been studied, hopefully in their more longitudinal follow-up, will address this as well. And as you know, there are still some that haven't yet made it to emergency use authorization. So I would really hope that those, as they approach their various clinical endpoints, would also measure the nasal carriage or lack thereof of virus in their study design. So hopeful news, but not definitive just yet. I think the proof will be in the pudding as we watch the vaccination efforts continue to progress across the country, and we look at our cases across the country, especially before winter ends, so that we could see that perhaps maybe people are able to not transmit the virus to one another as frequently.
Thank you. And I had a question for Secretary Smith. I understand that the first efforts to vaccinate people who are homebound will be through organizations like Visiting Nurses. how are things progressing with arranging for vaccinations through emergency medical personnel for those people who are not clients of a visiting nurse organization?
Yeah, thank you, Joe. As I mentioned in my remarks, we are currently putting a program together for them as well. We want to get through this first tranche of those that are home health, associated with home health, because it's easier to identify those individuals. But as I mentioned last Friday and today briefly, we're reaching out to all sorts of providers, municipalities, those sort of avenues to get some insight into who may be out there. We also may at some point ask people to call us so that we can get the information for that. That's not right now, but we will be probably reaching out to those individuals to give us a call so that we can put them on a list. So there's various avenues that we're working on. I said we should be turning to them in the next 2 weeks or week and a half as we start wrapping up the program through the home health agencies and the EMS.
Thank you.
Derek, 7 days. Derek, star 6 to unmute.
Can you hear me now?
We can.
Okay, sorry about that. This first question is for Dr. Levine. There was a study out today, I believe, about the exceptional risk for contracting and dying from COVID amongst people who have dementia. I'm wondering if health officials here have done any sort of analysis or taken a look at this in Vermont, and whether or not these findings have implications for our vaccination plan. For instance, whether people with dementia would deserve to be on the list of health conditions that would be eligible sooner.
Yeah, thanks for bringing that study to attention. It is relatively breaking news, as you would say, just being announced today. Just so people understand, it showed the increased risk having dementia has on COVID and on outcomes in COVID. One important thing was it was able to control for other factors that you might think happen in affiliation with having dementia, such as living in a long-term care facility or having chronic diseases other than dementia that might increase your risk. So even when controlling for those factors, dementia alone had an increased risk. Reasons behind that probably have to do with some of the manifestations of dementia. Someone who's having cognitive and memory impairment, sometimes behavioral issues, unable to accommodate wearing a mask consistently, unable to physically distance as consistently, sometimes prone to wandering in later stages. So those would all increase somebody's risk of community transmission, depending on the circumstances. We are in the process of doing something that we did many, many months ago, earlier in the pandemic, which is report on all of our deaths and look at all of the risk factors that those people had in terms of the long-term problem with the pandemic, not just an early report. So we'll have a little more news on that, but I can tell you that the coexistence of being in a long-term care facility and having dementia is very, very high in those people who have died. It's not the only reason, obviously, but there are many people who have been suffering from dementia in these long-term care facilities and were very susceptible to COVID and susceptible to having a bad outcome as well with COVID. So I'm sure that's what we're going to be able to show when we have a definitive report and that's completed. For those who have not been living in long-term care facilities and are living at home, my most important counseling would be, of course, because of their increased risk and because of the inability to comply with some of the guidance that I mentioned earlier, that their caregivers be very, very attentive and pay special attention to the circumstances that these individuals find themselves in with regard to where they are in public, where they are with visitors, etc., knowing that they do harbor a special risk for dementia and have to be taken care of carefully. Fortunately, but not exclusively, dementia is a condition that certainly presents well after 50 and often in later years. So I would hope that the majority of individuals will at least get back into the 65 and older age range and be taken care of relatively quickly here in our vaccine strategy in Vermont. Whether it becomes a defining condition on the chronic conditions, I would venture to say that if this report, after it's been peer-reviewed and critically appraised at the level of the scientific community and the CDC, if it merits having dementia be placed on the list, that will happen relatively quickly, and we will certainly add it to our list as well.
Thank you. My other question, if I may, is for the governor. It appears that there is a plea agreement in place for Veronica Lewis, who's charged with attempted murder from 2015, and this is one of the cases, Governor, that you had requested the Attorney General take a closer look at. I'm wondering if you're aware of the plea agreement and if you think it does justice in the case.
I am not aware of the plea agreement, so I can't really comment on that.
Okay. All right, thank you.
Aaron, VT Digger.
Hi. I was looking at the DFR presentation, particularly the regional vaccination map, and I noticed that you've kind of changed up these numbers here. First off, last week you said we were second in the Northeast. Now you say we're second in New England, presumably behind Connecticut, because that looks pretty dark. And we've also fallen from 8th nationally to 10th nationally. I was wondering why you decided to change the way that you compare Vermont to other areas, and are you concerned about the fact that Vermont is starting to fall behind in its vaccination rate?
Commissioner Pichek?
So Governor, thank you. I just maybe a point of clarification. I'm not understanding how we changed our analysis. I think maybe there was a concern about language. I think our intent was always to look at New England. And if you include the Northeast, which generally would be maybe adding New York, we would still be number 2, both last week and this week. So maybe a language issue, Aaron, but I'm not seeing how we changed our metric at all. In terms of your concern about where we rank, this week we saw us oscillate between number 7, number 8, number 10 in the country in terms of vaccination. Some of it's timing, some of it's, reporting timing and things like that. But, we're just as likely to be number 7 tomorrow as we are to be number 10. So, we're near the top, and I think that's what's critically important. But again, we've generally ranged between, that sort of top 10 and that second half there between 7 to 10 in the country.
Yeah, well, the map itself shows the entire travel region, and in previous weeks, I'm pretty sure you've said that we're second behind West Virginia. So that's obviously not just comparing us to New England.
Yeah,
now
I think that's right.
It's like we're third behind West Virginia and
Right,
Connecticut. Yeah.
Right. In the past, we've made it very clear when we're talking about the travel region or the Northeast. So, the travel region is all of those places. The Northeast obviously is in Ohio and Maryland. So when we've included the Northeast, we've made that obviously particularly clear. When we've included the country, we've made that particularly clear. We think those are the two most relevant, basically. How do we rank against the entire country? And how do we rank relative to the states closest to us?
Are you aware of how Vermont ranks in terms of the number of people vaccinated per week per capita? recent weeks since we've changed our guidance?
I'm sorry, could you ask that question again?
Has the pace of vaccination changed? And by how much?
So I think, consistent with the increased doses that other states are seeing, Vermont has seen the pace at which the number of people vaccinated has increased in recent weeks. That's a trend that we've seen nationally as well.
All right, that's 3 questions, so we're going to move to Tom. Aaron, if you have more questions and we have time at the end, I can go back to you. Tom, the Vermont Standard. Tom, the Vermont Standard. All right, we'll go to Eric at the Times-Argus.
Yes, this is about a question about these federal programs and how they're going to work logistically with the state. If someone can sign up for a vaccine through the state, or they can sign up through Walgreens and they want to cover both their bases, and the Walgreens appointment comes up first, what happens with the state appointment? Are state officials preparing for missed appointments, possibly spoiled vaccines?
Secretary Smith.
Thanks, Eric. Those are questions we're looking at right now. You're absolutely right. The more sort of inbound ways that you come into a vaccine program does create more complications. We're happy for it because it means more vaccines for Vermonters, but it poses a lot of complications for all the programs trying to work together, especially when you have an outside program that's not really connected to the state's registration program. We're trying to work those issues out right now. I think we'll come up with solutions, and the solutions will have to be sort of close communications with, like we have right now with the Kinney's drugstores. We are almost connected quite a bit in terms of what we see with Kinney's vaccination program and what we have. And matter of fact, it's very coordinated with us. We're just going to have to work through the Walgreens issue. I think, A, we got to be happy that we're getting more vaccine. B, we got to be happy that we're getting more sites. But C, it does bring complications into the process that we're just going to have to work out. We're going to have to figure it out on our end. We're not going to sort of, the better way to do this is to have more opportunities for Vermonters and let us try to figure out how to accommodate all that.
Federally qualified health centers that the governor mentioned for the governor's meeting, is that the same as the Walgreens program, or is that a separate program?
That's even a separate program from the Walgreens. The Walgreens is a federal program. The FQHC actually may be easier to do because we do have connections that we can probably work for. But this, what the governor announced today is something that we're going to have to go back to the shop and work out and try to figure out how we make sure we're all coordinated as we move forward.
Okay, thank you.
Again, I think that the question is something that is on the minds of many. I think across the country, governors on both sides of the aisle are concerned. We're appreciative of receiving more vaccines, but every time they develop a new program, it adds a layer of complexity, and we just want to make sure that we're doing this in a seamless way. I think the common message, I think, from most governors would be to the federal government, please keep increasing the supply and let us handle the distribution. I think that would make it a little easier. We appreciate their support, but that's an area that I think we could do just as well.
All right, we'll go to Tim at Vermont Business Magazine.
Hi, good afternoon, Dr. Levine. We've been hearing a lot about reactions to the second dose, and one doctor said he hoped he would get a reaction to the second dose. And I wonder if you could explain that, and people might be concerned if they hear that people are getting a reaction and what that means, and should they be concerned?
Absolutely. Thanks for that question. And reaction is a common word and a common event. And in vaccine talk, reaction, there's another word that reactivity. The vaccine is meant to create an immune response in the person who gets vaccinated. And it's known with the mRNA vaccines that the second dose may actually have more of those symptoms you would get of reactogenicity compared to the first dose. And so, again, these are not to be feared in terms of major side effects like anaphylaxis or something terrible of that sort. These are things like a low-grade fever, achiness in muscles or joints. In some cases, some swelling in the lymph node area under your arm. Those are all signs your body has actually made antibodies and is working on this immune response based on getting a vaccine. So second dose, more likely than first dose, relatively common, generally short-lived within a 24, no more than 36-hour kind of period.
Is there any group of people who should be waiting for the Johnson & Johnson one-shot vaccine for any reason, including these reactivity?
You know, I have to reserve comment and judgment on that because we need to see all the data from Johnson & Johnson and hear what the advisory panels think of the data. And so it'd be a little premature because that's not even going to happen till, I believe, the 26th of February. So I don't want to just expound on something that I don't have enough insight into yet.
Would your advice be, if you're in the age band 75 plus 1A, that go ahead and just get the double dose, the Pfizer or the Moderna?
Well, right now that's your only option. If and when the Johnson & Johnson comes along, I can without commenting on the adverse effects, because that's, again, something I need more insight into, I can comment on the fact that its effectiveness in preventing the most serious illness and preventing hospitalizations and death is equal to the other vaccines that are out there now, according to the preliminary data I've seen. And in that case, I would tell anyone that whatever vaccine is available for them to get in a timely way, they should get, because they're going to enjoy the same favorable outcome.
Okay, great. Thank you very much.
I want to just take 1 second to correct one thing I said in my opening comments, just talking about, because I do want people in Bennington County to avail themselves of testing. And I mentioned that on Saturdays we have the Northshire Medical Clinic. I've been corrected in saying that it's the SVMC Northshire campus in Manchester, just to prevent any confusion. Thank you.
Guy Page, Chronicle of the Vermont State House.
This is listening for the Governor or Administration Secretary Suzanne Young. Secretary Young, you were on the January 25 Vermont Climate Council Zoom call when Massachusetts climate official David Ismay advised that you all, he said, 60% of our emissions that need to be reduced come from you, the person across the street, the senior on fixed income, right? There's no bad guy left, at least in Massachusetts, to point the finger at, to turn the screws on, and, you know, to break their will so they stop emitting. That's you. We have to break your will, Mr. Ismay said. So my question is, should the Vermont Climate Council and the state of Vermont, quote, turn the screws on and break the will of Vermont citizens, including our seniors on fixed income? What do you make of that statement?
Thank you. I did find that statement very interesting, and I think that the Vermont Climate Council will take a look at the science and the data. If you look at the statute, it's very much driven by
doing the inventories of our current programs, what works, what doesn't work, finding the gaps, and then determining what is affordable for Vermonters, what is fair and equitable. And I think that the Global Warming Solutions Act does provide the council with a roadmap forward to present a plan that works for all Vermonters. And that's how I would intend to lead the council through its work.
Thank you. Governor, you've been insistent that people entering Vermont must follow quarantine and testing guidelines. I've heard reports that people are flying in from Nevada for 4-day ski trips, obviously not quarantining, and also that people entering the U.S. illegally through the Swanton sector may be detained and then, per the new administration's directive, released. Are you following either of these situations, and is anything being done about them?
Guy, I haven't heard of either of those situations, not the flights in from Nevada, nor the coming across the border either. So I'm not aware of those. In terms of those coming into the state and not quarantining, again, I'm not naive. I believe it is happening, and we're just trying to mitigate as best we can. We're trying to provide the guidance necessary, educate where appropriate. And in your previous comment to Secretary Young, I think you've seen over the last 4 years, I prefer the carrot approach versus the stick approach, and I would utilize it in this way as well as with climate change as well.
Thank you.
Ian Wallace-Allen, VT Digger.
Hi, this question is for Commissioner Harrington. So it sounds as though the 180,000 1099-G forms that the Department of Labor printed out recently contain full Social Security numbers, and that's what's caused a lot of the problems with the mailing. So the IRS allows payers to truncate or mask Social Security numbers to avoid this kind of breach, and I'm wondering, is this something the Labor Department would consider doing in the future, or for this mailing, in fact, that it's sending out soon of new 1099s?
Thank you, Ian. The one clarification I want to make is the 180,000 is the total number of 1099s that the department will be issuing. In terms of what actually went out the door, that number is much less. And when you look at the ones that actually had correct information, that number is even less. So, but with regards to your question, I'm certainly not opposed to that. I'd have to do some more research and make sure that that is allowable under the unemployment insurance program, which is federally regulated. So from that perspective, I don't think anybody is opposed to putting in actions that increase identity protection and further support that level of protection. But I would just need to confirm that that is actually allowable under the unemployment insurance program.
Is it something that you guys have considered? And I do realize the 180,000 is just the number printed, not the number that went out.
It has not been something that has come to my attention yet, but I would be happy to bring that back to the team and see if that is actually something that is allowable under the law.
I'm just hearing from a lot of people who are saying, why was it on there in the first place? Thanks very much.
As well, as you know, I've spoken to the Auditor of Accounts and asked him to review the situation. This may be one of his recommendations. We'll see, amongst many, but that's why we've asked for their advice and them to take a look.
Thank you.
Andrew, Caledonian Records.
Yes, thank you. Good afternoon. This is for Governor and/or Secretary French. Wondering about your potential support of Senate 63, which is in the Senate Education Committee right now, that would prohibit schools from contracting with law enforcement agencies for school resource officers. I know a couple of the Kingdom high schools currently have school resource officers.
Yeah, I can tell you from my perspective, I'll let Secretary French answer as well, but from my perspective, this has been, school resource officers has been utilized successfully in Vermont in some areas. This is truly a local decision, and it should be left as such. I don't believe that we should, as a state, preclude that from happening. I think that the districts are well able to make those decisions on their own. So I would be opposed to that.
Yeah, Governor, this is Secretary French. Yeah, based on my experience, I would tend to agree. I think school districts use those SROs in many different ways and are perfectly able to, supervise how best to utilize those resources. And, that's something that I think that we should leave in the judgment of school boards and their superintendents and principals put aside.
Okay, thank you. And the second question, I think probably for Secretary Smith. This comes from a reader who recently received their first dose in the 75 plus bracket, and they were struck by the impression that it seems quite easy for someone to trick the registration system by either providing a fake date of birth or a fake name, and there was no request for ID when they showed up for an appointment. Are there any verification measures at either the registration level or the appointment level that people are deemed eligible to receive a vaccine when they show up?
We discussed this maybe 3 press conferences ago. You do the attestation when you sign up. We take Vermonters at their word when they're signing up. The reason we don't have any sort of ID at the facility, other than we will ask you questions and make sure it's your name. The reason why we don't have any others is many of these people that are 75 and plus, it's hard for them to have some form of documentation, whether a driver's license in some cases that they don't have, or others. So we want those people to come in, feel comfortable, not worry about ID when they get into the facility, and be able to get their shot. So we asked people to attest, and the governor and I both said at the beginning, you can game this system. We ask you not to game the system because you're taking a vaccine away from somebody that is in a high-risk age group. 90% or more of our deaths have happened 65 and above. And if you take a vaccine away from one of those people, you are literally taking away somebody's opportunity to be healthy and not be hospitalized or not tragically die from this. So I would urge Vermonters not to do that. But to answer your question, at the site, there is no verification. It is, as the reader said, very easy to get vaccinated.
Thank you very much.
Ed, Newport Daily Express.
Hey, thanks for letting me be on here. I know last one. It's been a long ride here, guys. My question actually is more for Dr. Levine, which is even as I understand it, and I want you to please, talk to this rumor that even if you get vaccinated, you can still have the virus, and you can still transmit it. You're wearing masks or not. Dr. Levine, can you please turn around and kind of let us know what the truth of the matter is? Once you've been vaccinated, does that mean you're not a carrier, so to speak?
So point number one is, if you have a vaccine with 95% effectiveness, you need to know what the effectiveness is, and it's getting symptomatic illness versus getting a serious illness or a hospitalization. But that would mean a 5% chance of having an illness. As vaccines go, that's phenomenal. That's absolutely phenomenal. The flu shot, many seasons, the best we can hope for is maybe 60% effectiveness, 70% on a really good time. The stuff I talked about from AstraZeneca a few questioners ago has to do with if you do get vaccinated, will you have a nasal swab that could turn positive for COVID? And there was a 2/3 reduction in the positive nasal swabs in the vaccine group compared with those who didn't get the vaccine. So that's very promising as well, but that's early data, and we don't have more definitive data yet, but we're hoping it's coming soon. With regard to can you transmit the virus, well, if the AstraZeneca data is really true, then there would be a far less likelihood of you being able to transmit the virus, but there still would be some likelihood you could transmit the virus. Doesn't mean you would, because presumably you might not be coughing and sneezing and close to people in ways that you could transmit the virus, but you could potentially do that unless the virus itself got weakened by the fact that you had an immune response and were able to attack it even at the level of your nose. So little unclear there yet. We don't have the definitive word, but it's really promising. And I should say that most vaccines, we wouldn't even talk about this. We assume that if you've got a respiratory virus that the vaccine is effective against, it's going to prevent transmission as well as prevent you from getting sick. But we're making a much bigger deal with this very novel virus that we've never had before and wanting to be very specific about having results that prove that. But we should expect that it would certainly markedly reduce the ability of a person to transmit the virus to others. Okay?
Thank you very much. Have a good day, guys.
And we are going to try to go back to Mike Donahue from the Islander, who couldn't get through earlier. Mike?
Thanks, Rebecca. Commissioner Harrington, a couple questions. First, what would it take for you to consider providing more than 1 year of protection to those people that have been compromised by the actions of the Labor Department, specifically the, obviously, Social Security numbers, dates of birth, and other personnel information are, when they're stolen, they're sold, recycled well beyond the 12-month period. What would it take for your department to protect people beyond 12 months?
Thanks, Mike. I would say that we are considering that. There is a team between here at the department and our general counsel, along with the response team that the governor sent over, including his general counsel and the administration, looking at the vendor and what the vendor can offer, also looking at the contract as well. So again, I don't know the details to date in terms of everything that has happened with regards to the scope of the contract, as that is changing actually by the minute in some cases. But I do believe we have looked at also the length of the term for coverage as well.
Okay. And the other question, I received a copy of a Department of Labor memo issued a couple days ago that apparently removes the 3 safety inspectors away from their specific duties, checking Vermont ski lifts, and reassigns them to patrolling parking lots and lodges and lift lines at ski resorts to make sure they're in compliance with Vermont rules instead of making sure they're safe, the lifts are safe. These guys, I understand, are solely funded by the ski areas to ensure safety, and a reader is concerned about reassigning state inspectors to police parking lots, and they say that since the skiers who ultimately pay, they probably wouldn't be happy to know the inspectors are spying on skiers in the parking lot instead of focusing on safety of the lifts. They apparently are going to be looking, according to your memo, or the department memo, whether the lift lines are being managed so people are 6 feet away, that lifts are loaded at 50% capacity, and lifts are being loaded to facilitate 6 feet of social distancing between households, and whether people are wearing masks in lift lines and in other common spaces. Will the Labor Department also begin similar spying programs at grocery stores, pharmacies, schools, and restaurants?
Well, I don't think the that your articulation of the fact that it's a spine program is very accurate or appropriate. But I would say that just so people know the background here, this was actually a partnership between the Department of Labor's Tramway program along with the Agency of Commerce and Community Development to provide additional resources for oversight and compliance with the idea that if we felt that certain COVID mitigation steps weren't being followed, that we would bring that to the attention of the ski area so that the ski area could address that. I'll also point out that this level of review or oversight is happening as part of their normal daily job as well as during overtime. And so we have authorized some additional overtime to allow them to be at the ski areas simply to provide additional support and oversight at the ski areas. Again, looking to make sure, like you said, that certain protocols are in place, social distancing is in place, masking is in place, and making sure that the ski areas are following the guidance and expectations that the state has put out. Again, at this point, all we are doing is observing and then reporting those observations back to the ski area so that the ski area can address an area of concern. And so from that perspective, there's no level of enforcement going on, simply observation and then allowing the ski areas to address the concern as it comes up.
So there's no enforcement here, so the ski areas will be told too many people are not wearing masks, and so nothing will be done, much like in grocery stores and pharmacies and schools, restaurants, whatever, that there's nobody enforcing. They're just taking down information that isn't going to be used.
From the position of the passenger tramway program, all we have been asked to do at this point is to observe during our regular tasks or with approved overtime while we're at the mountain conducting regular inspections as we typically would, that if we observe that any type of exposure mitigation effort is not being followed, that we simply bring that to the attention of the ski area so that they can address it.
Okay, thank you very much.
Before we are right up against our time, but I did want to go back very quickly to Erin Patenko's 2 additional questions she squeezed in and have Commissioner Pichek provide some info on that. One was what our per capita ranking was for vaccination distribution, and then if our vaccination rate is, or our pace of vaccination is increasing as we're in the 75 plus category. Commissioner Pichek?
Yeah, thank you very much, Rebecca. I guess on the first point about the ranking, I mean, every ranking that we've put up is looking at Vermont per capita relative to the rest of the country. And in terms of vaccine administration, the presentation today includes that we're number 10 in terms of administration nationally, number 2 in New England and in the Northeast. And in terms of distribution, we are equally in the top 10 and generally have been in terms of the amount of vaccine distributed to Vermont, again, on a per capita basis. In terms of the second part of the question about the speed or the usage, I mean, one way to measure that is the percent of doses used as a simple metric. And, Vermont generally was in the 50%, upward of close to 60% range, at the start of the vaccination program, and more recently has been in the 70 to mid and high 70% range in terms of doses used. But I will also point out that all of the states across the country have also improved. Many of them were in that 50% range, or even first doses used in the 70, 80, and even in the 90% range, depending on the particular state.
All right, thank you. I think we're all set.
Okay, all right. Thank you very much for tuning in. We'll see you again on Tuesday or Friday.